Welcome back to the Deep Dive. Today we are shifting gears a little. We aren't just talking about health in general. We are walking into a high-stakes environment. We're talking about a chemical reactor, a mechanical grinder, and really a battlefield for one of the most common infections in human history.
It really is a battlefield. It's hostile territory inside your own body.
We were talking about the stomach and the duodenum.
Mm.
And look, I know what you're probably thinking. The stomach is just a bag, right? You
Yeah.
put food in, it churns it up and sends it on its way.
Yeah.
But when you actually peel back the layers, literally and metaphorically, it is so much more complex.
It's a machine.
It's a machine that has to handle acid strong enough to dissolve zinc while somehow not dissolving itself.
Which is just... It's an incredible feat of engineering. And when that machinery breaks or when that protection fails, the consequences are, well, they're immediate and often catastrophic.
Exactly. And to guide us through this, we are doing something a little different today. We're getting specific. We are doing a dedicated revision session based on what is, let's be honest, the absolute Bible of surgery. We're diving into Chapter 67 of Baily and Love's Short Practice of Surgery, the 28th edition.
Which is a heavy book. Physically and metaphorically very dense.
So here's our mission today. If you're a medical student, a surgical trainee, or just someone who wants to understand how this organ really works at a deeper level, this is your ready reckoner. We're going to interpret this chapter. We aren't just going to read it to you. That would be boring and, frankly, a waste of your time.
Yeah, nobody wants that.
We're going to give you the mental anchors, the metaphors you need, so that when a consultant grills you in the operating theater or when you're staring at a multiple choice question that looks impossible, you have the answer just locked and loaded.
And a quick disclaimer before we start.
Yeah.
This is an interpretation. It's a revision aid. It is absolutely not a substitute for actually reading the chapter. You still have to do the reading.
We do.
But we're here to make that reading stick. We want to provide the scaffolding, so when you do open the text, it feels familiar. It clicks into place.
Ideally, yeah, we want you to listen to this and then go open the book and suddenly everything makes sense. So here's the roadmap for the next 40 minutes or so. We'll start with the fortress itself, anatomy and physiology.
You have to know the plumbing and the wiring before you can understand the leaks.
Exactly. Then we're going to talk about the revolution Helicobacter pylori.
The bug that changed. I mean, it changed the entire paradigm of upper GI surgery.
Then we'll move to peptic ulcer disease, the war between aggression and defense. We'll take a walk through the Surgical Museum of History because you can't understand modern complications without understanding the old surgeries. And finally, we'll hit the heavy stuff. Emergencies like perforation and bleeding, and the silent killer, gastric cancer.
It's a full menu today.
Pun fully intended. Let's get into Section 1, the fortress, anatomy and physiology. Now, Baily and Love describes the stomach not just as a bag, but as a reservoir and a grinder. They use this fantastic phrase, the antral mill.
That's such a key distinction that people often miss. We tend to think of the stomach as, one uniform sac, but it's really two organs in one. The top part, the fundus, and the body, that's your storage tank.
Right.
Its job is receptive relaxation. You swallow a meal, and the muscle tone actually drops to accommodate the volume without raising the pressure inside.
So it's the waiting room for the food.
Exactly.
Yeah.
But the bottom part, the antrum, that is a powerful muscular grinder. That's the antral mill. It churns the food against a closed pylorus, the exit valve. It literally mills the particles down until they're less than 2 millimeters in size.
Wow.
Only then does the pylorus open and let them through to the duodenum. It's mechanical digestion before the chemical digestion really takes over.
And like any heavy machinery, it needs a massive power supply. Let's visualize the blood supply. I always find this tricky because there's so many vessels with similar sounding names, but Baily and Love breaks it down really nicely into a dual arch system. I want to try and build this map in our heads right now.
Let's do it. Visualize a stomach. It's J-shaped. You have the inner tight curve, the lesser curve, and the outer big sort of ballooning curve, the greater curve.
Okay.
Baily and Love wants you to imagine a continuous arterial arcade running along both of those curves. It's like a frame.
Okay, let's unpack the lesser curve first, the inside track.
Right. On the lesser curve, you have the left gastric artery coming down from the top. It branches directly off the coeliac axis. It's a big high-pressure vessel. It runs down the curve. Then coming up from the bottom to meet it is the right gastric artery.
And here's the trap for students, right?
Yeah.
Where does the right gastric come from? It's not the same source.
No, it usually comes from the hepatic artery, the liver's blood supply. So you have the left coming down from the coeliac and the right coming up from the hepatic. They meet, they kiss in the middle of the lesser curve. That's your first arcade.
Simple enough. Left from coeliac, right from hepatic. Now the greater curve.
The long way round.
Similar concept, just a bigger loop. You have the left gastroepiploic coming down from the splenic artery on the left side, and you have the right gastroepiploic coming up from the gastroduodenal artery on the right. They meet along the bottom of the stomach.
So you have these two perfect loops. It's like a picture frame. But there is a trap here, isn't there? There's a watershed area. A part of the stomach that isn't invited to this arterial party.
This is so critical, and it's a classic surgical pimp question. The fundus, the very top dome of the stomach, it isn't supplied by these main loops. It sits way up high, right next to the spleen. It's supplied by the vasa brevia, or the short gastric arteries.
And where do they come from?
The splenic artery. They are fragile, tiny little branches that run from the spleen to the stomach. Okay, so why does that matter in the real world?
Well, imagine you're a trauma surgeon. You have a patient with a smashed spleen. You have to remove it, and you have to do it quickly to stop the bleeding. If you're clamping the splenic artery aggressively, or if you sacrifice those little vessels without thinking,
You've cut off the blood supply to the top of the stomach.
you've just devascularized the fundus. It dies. The sclerosis of the fundus, the stomach perforates a few days later. It's an absolute disaster. So remembering the short gastrics isn't just trivia. It's about not killing your patient during a splenectomy.
Okay, that's the fuel lines. Powerful anchor. Now let's talk about the wiring, the nerves, the vagus nerve.
The vagus is the boss here. It really is. It drives acid secretion and it drives motility. You have two main trunks coming down the esophagus, the anterior and the posterior.
And they split up as they hit the stomach, right?
They do. They fan out. But the parts we really care about for the antral mill are the nerves of Latarjet. They look like a crow's foot termination right on the antrum. They are the nerves that tell the mill to grind. If you cut them, the mill stops. The stomach can't empty.
But there is one specific nerve mentioned in the text that has, I think, the best name in all of anatomy, the criminal nerve of Grassi.
The criminal nerve. It sounds like a character from a pulp fiction novel.
So why is it criminal? What did it do?
It's called criminal because it is guilty of causing recurrent ulcers. It's a branch of the posterior vagus that sits high up, often tucked away behind the esophagus. Back in the day when surgeons used to cut the vagus nerve to stop acid, which we'll talk about later, they would often miss this one little branch because it was just hiding.
So they do the surgery, they think they've fixed the problem.
Exactly. They'd finish the operation, think they'd stopped all the acid, but the criminal nerve was still there, lurking in the shadows, still telling the stomach to pump out acid. The ulcer would come back. It's criminal to miss it.
I love that. I will never forget that now. The criminal nerve of Grassi. The one that got away. Okay, let's zoom in now. We've done the gross anatomy. Let's go microscopic. We're inside the factory. We have three main workers here that Baily and Love highlights.
Right. You have the parietal cells, the chief cells, and the G cells.
Let's do a quick roll call. Parietal cells.
They're the heavy lifters. They're located in the body of the stomach. They produce two things: hydrochloric acid, HCl, and intrinsic factor. And you can't forget intrinsic factor. Without it, you can't absorb vitamin B12, and you get pernicious anemia.
Okay, the chief cells.
They're the enzyme makers. They produce pepsinogen. This is the precursor to pepsin, the enzyme that actually digests protein. It's secreted as an inactive form, so it doesn't digest the cell that made it.
Glamour.
And once it hits the acid in the stomach, boom, it activates into pepsin.
And the G cells.
The managers, the supervisors, they are found in the antrum, the exit, and they secrete a hormone called gastrin. Gastrin is what shouts the instructions. It travels in the blood all the way back up to the parietal cells and tells them to get to work.
So G cells scream, food is here, and the parietal cells start pumping. Let's talk about that pump, the food. I mean, this is the target for so many of the drugs we use today, the proton pump.
It's the H plus K plus AT pace pump. This thing is a marvel of biology. It pumps hydrogen ions, which are, acid, out of the cell into the stomach lumen. But here's the crazy thing. The stomach is already incredibly acidic. The cell is neutral, so it is pumping acid into a place that is already millions of times more acidic than itself.
Baily and Love puts the gradient at something like 1 million to 1.
1 million to 1. Imagine trying to push one person into a stadium that already has 1 million people crammed into it. The pressure pushing back is just immense. That's the kind of energy required. It swaps a potassium ion to get a hydrogen ion out. It brings a massive amount of ATP energy.
And this is why proton pump inhibitors, PPIs like omeprazole, are so effective.
That's exactly it. Older drugs like ranitidine or Zantac, they only blocked the signal, the H2 receptor. But PPIs, they jam the pump itself. They stop the final common pathway. It doesn't matter how much gastrin or acetylcholine is screaming, make acid. If the pump is jammed, no acid is coming out.
But if the stomach is full of this, I mean, it's essentially battery acid, why doesn't it digest itself?
The mucus barrier. It's a force field. It's a thick layer of mucopolysaccharides and bicarbonate that coats the entire lining. It's not just slime, it's an active chemical shield. It neutralizes the acid right at the surface of the cell, keeping it safe.
And if that barrier breaks,
You get an ulcer.
okay, let's pause right there. We've covered the fortress. I want to do a quick check-in with you, the listener. Don't look in your notes. Close your eyes if you're not driving. Can you visualize that blood supply?
Think about those arcades that frame.
Can you name the 4 main arterial branches? Left and right gastric on the lesser curve, right and left gastropiploic on the greater curve. And the trap what supplies the fundus.
The short gastrics.
And ask yourself, which nerve is the criminal responsible for recurrent ulcers because it hides high up on the posterior side?
That's the nerve of Grassy.
If you couldn't visualize that blood supply, or if you forgot about the short gastrics, hit rewind. Go back to the start of the anatomy section. You really need this mental map because when we start talking about cutting things out later, you need to know what we're cutting.
Absolutely. The anatomy explains all the complications.
Okay, moving on to section 2, the game changer. We are talking about Helicobacter pylori.
It's just wild to think that not that long ago, in the grand scheme of medicine, we all thought ulcers were caused by stress or spicy food or just having a type A personality.
The executive's disease, they called it.
It was dogma. No acid, no ulcer was the rule, but nobody knew why the acid regulation was breaking. Then came these 2 guys, Warren and Marshall, in the early 80s from Australia. They identified this spiral bacterium in the stomachs of people with gastritis.
And the medical community basically laughed at them.
They were ridiculed. Utterly. The thinking was, the stomach is sterile, nothing can grow in pH2 acid, it's impossible. They were told it was contamination from the scope.
Marshall was convinced.
Oh, he was. And he did something that is now just legendary in medical history. He couldn't get his theory accepted, he couldn't prove it in animals, so he grew a culture of the bacteria.
And he drank it.
He drank the beaker of H. pylori. Within days, he was vomiting, he had terrible halitosis, and a biopsy showed he had developed massive acute gastritis. He proved Koch's postulates on himself.
That is dedication.
It's incredible. They won the Nobel Prize in 2005 for this. It shifted the paradigm from a surgical or a psychological disease to an infectious disease.
But that begs the question, the deep dive question. How does a bacteria survive in a bag of acid? You just told me the proton pump creates 1,000,000 to 1 concentration.
It wears a spacesuit.
A spacesuit.
Metaphorically, yeah. H. pylori has an enzyme called urease. This is its superpower. It takes urea, which is naturally present in the stomach juices, and it breaks it down. It hydrolyzes it into carbon dioxide and ammonia.
And ammonia is a base, an alkali.
A strong alkali. So the bacteria literally surrounds itself in a little cloud of ammonia. It neutralizes the acid immediately around it. It carries its own little microenvironment. It's like walking on the surface of Mars inside your own personal bubble.
Yeah, it's just incredibly clever evolution. So it survives. But how does wearing an ammonia suit cause an ulcer?
It's a domino effect.
Yeah.
First, the ammonia cloud itself is toxic to the epithelial cells. It burns them. That directly damages the protective mucus barrier we just talked about.
Right.
But secondly, and this is the really clever part, it messes with the signaling. The ammonia makes the stomach environment seem alkaline to the chemical sensors.
So the sensors think there isn't enough acid.
Right. The G cells, the managers, they go, whoa, the pH is way too high in here. We need more acid. So they release more gastrin. You get this state called hypergastrinemia.
So you have a bug that's damaging the shield, and at the same time, it's tricking the factory into producing way more acid. It's a double hit.
It's the perfect storm. And this leads to something called duodenal metaplasia. This part always confuses students. If the bug is in the stomach, why do you get an ulcer in the duodenum?
Yeah, please explain that.
The duodenum is not built for high acid. It expects the chyme to be neutralized by the time it gets there, but because of this hypergastrinemia, you have a huge load of acid just dumping into the duodenum. So the duodenum tries to adapt. It changes its lining to look more like stomach lining. That's called gastric metaplasia. It's trying to armor up.
But that backfires.
Massively. Because now that it looks like stomach lining, H. pylori goes, hey, that looks like home, and it colonizes the duodenum too. So the infection moves into the duodenum, causes inflammation duodenitis, and eventually it erodes right through, and that's your duodenal ulcer.
That makes so much sense. So if we suspect this spacesuited invader, how do we find it? Baily and Love lists a few tests.
You can do a stool antigen test, which is easy and non-invasive, but the classic text descriptions are the breath test, the C13 or C14 urea breath test. You give the patient labeled urea to drink. If the bug is there, its urease enzyme breaks it down, and you literally breathe out labeled carbon dioxide. It's very elegant.
And if you're already doing an endoscopy,
You take a biopsy, and you use a CLO test. That stands for Campylobacter-like organism test. It's a little slide with urea and a pH indicator. You put the piece of stomach tissue on the slide. If the bug is there, it makes ammonia, the pH goes up, and the slide changes color from yellow to red. Simple.
and the fix, we don't do surgery for this anymore, thank goodness.
No, triple therapy. You have to nuke it. It's usually a PPI to stop the acid, plus 2 antibiotics, classically clarithromycin and amoxicillin, or metronidazole if they're allergic. You have to attack it from multiple angles to really clear it.
That brings us perfectly to Section 3, peptic ulcer disease, or PUD. We know the main causes now, mostly H. pylori and SRIs like ibuprofen, but Baily and Love draws a really sharp distinction between duodenal ulcers, DU, and gastric ulcers, GU. It's a tale of two locations, and they act like two totally different diseases.
They really do. The whole patient profile, the symptoms, everything is different.
Okay, let's profile the duodenal ulcer patient first.
Typically, this is a high acid state. They have that hypergastronemia we just talked about. They're often a bit younger. The classic symptom is hunger pain. The pain comes on when the stomach is empty or at night.
That waking up at 2 a.m. thing.
That's the classic sign. Acid secretion peaks at night. And here's the key. Eating often relieves the pain.
Why does eating help?
Well, 2 reasons. First, food buffers the acid. It just soaks it up. And second, eating closes the pylorus for a while, which stops the acid from squirting directly onto the ulcer in the duodenum, so they eat to relieve the pain. These patients might actually gain weight.
Okay, let's talk complications. Location is everything. Where exactly do these things form?
Usually in the first part of the duodenum, what we call the duodenal cap. And here is a crucial anatomical anchor for you. This is one of those rules you just have to burn into your brain. You need to know the difference between an anterior DU and a posterior DU.
Okay, lay on me.
Anterior ulcers tend to perforate.
Anterior air.
Right. Think about the anatomy. What is directly in front of the first part of the duodenum? Nothing, just the free peritoneal cavity. If the ulcer burns through the anterior wall, it opens right into the abdomen. You get air and stomach contents leaking everywhere. Peritonitis.
And posterior.
Posterior ulcers tend to bleed.
Why? What's back there?
The gastroduodenal artery. It runs directly behind the first part of the duodenum. If the ulcer erodes backwards, it hits that high-pressure artery. It eats into the vessel wall. That's a bleeder.
That is such a high-yield fact. Anterior parates, air, posterior bleeds, artery. Got it. What about these kissing ulcers I've read about?
That's just when you're unlucky enough to have both at the same time, an anterior and a posterior ulcer facing each other across the lumen. It sounds romantic. It is anything but.
Now let's swap to gastric ulcers. How are they different?
These are different creatures entirely. The patient is usually older. Acid levels might be normal or even low. The problem here is a failure of defense. That mucus barrier is broken. This is often driven by NSAIDs, painkillers, or H. pylori, but also things like smoking and alcohol.
And what about eating?
Eating often makes the pain worse. Food stretches the inflamed stomach wall, and that stimulates some acid production. So these patients often lose weight because they're afraid to eat.
And the location.
Usually on the lesser curve, specifically at the incisura angularis, that's the notch on the curve.
And there's a specific, very serious danger with gastric ulcers that doesn't really exist for duodenal ulcers.
Malignancy, cancer. A duodenal ulcer is almost never cancer, but a gastric ulcer. It might look perfectly benign on the camera, but it could be an ulcerated cancer.
What's the golden rule?
All gastric ulcers must be biopsied, and not just once. You take multiple biopsies, you treat them with PPIs, you scope them again in 6 to 8 weeks to make sure they have completely healed, and you biopsy any scar tissue. If it doesn't heal, it's cancer until proven otherwise. You never, ever trust a gastric ulcer.
Let's try a fictional case study to lock this in. I'm going to throw a scenario at you.
Go for it.
Okay. A 45-year-old executive. High-stress job. He's taking a lot of ibuprofen for chronic back pain. He comes in complaining of a gnawing pain in the upper middle of his stomach. He said, "Doc, it wakes me up at 2 a.m., but if I go downstairs and eat a sandwich, it actually goes away for a while."
Okay, let's break that down. The ibuprofen is a huge risk factor for both, as it strips that mucus defense. But the timing is the absolute key here. Waking up at night when acid secretion peaks and the stomach is empty, that screams duodenal ulcer.
Right.
And the fact that food relieves the pain is the clincher. That's the food buffering the acid and the pylorus closing. If it were a gastric ulcer, that sandwich would likely have stretched the stomach wall and made the pain worse.
So for him, we're thinking DU.
Highly likely. You'd test him for H. pylori, tell him to stop the NSAIDs immediately, and start him on PPIs. But if he said that sandwich made the pain worse, I'd be worried about the stomach itself, and he'd need an urgent scope.
Section 4, the surgical museum. Baily and Love makes a good point that elective surgery for ulcers is rare now. The meds are just too good. We don't cut people open for pain anymore. But we still need to know the history. Why?
For two main reasons. One, you will absolutely treat elderly patients who had these surgeries 30 or 40 years ago and are now presenting with the long-term complications. You have to understand what was done to them to figure out what's wrong now.
Okay.
And two, when an ulcer perforates or bleeds uncontrollably and endoscopy fails, you still have to operate, and these classic techniques or versions of them come back into play.
Let's talk plumbing then, the reconstructions. Bill Roth the first and Bill Roth the second. These names come up constantly.
These are just ways to put the plumbing back together after you remove the bottom part of the stomach and entrectomy. So you've removed the antrum because it was full of ulcers or cancer. You have to reconnect the system somehow.
Bill Roth the first.
That's the most natural way. You cut out the antrum and you sew the remaining stomach directly to the duodenum, end to end. It's called a gastroduodenostomy. It's physiological. Stomach flows into duodenum just like nature intended.
But sometimes you can't do that. Maybe the duodenum is all scarred down, or the tumor was too big and the ends just don't reach. So you have to do a Bill Roth the second.
Right. Also known as a polyagastrectomy. Here, you close off the duodenal stump, you sew it shut, and just leave it as a blind alley. Then you grab a loop of jejunum, which is the next part of the bile, you bring it up, and you attach it to the side of the stomach. That's a gastroduodenostomy.
So the food skips the duodenum entirely.
Exactly. The food dumps straight from the stomach into the jejunum. But, and this is really important, the bile and pancreatic juices still come into that blind duodenal loop. They then have to travel down that loop and mix with the food later on downstream.
Okay, that's the reconstructions. And then there was the vagotomy, cutting the vagus nerve itself.
The whole goal was to stop the acid signal. If the vagus drives the pump, just cut the wire. Truncal vagotomy was the sledgehammer approach. You cut the main trunks right at the esophagus. It stops the acid, yes, but it also paralyzes the antral mill we talked about.
Yeah.
So the stomach can't empty. It just becomes this flaccid, useless bag. So they had to add a drainage procedure like a pyloroplasty, where you cut the pylorus muscle so gravity could at least drain the stomach.
They're brutal.
Already. Later, they got smarter with highly selective vagotomy. This was the sniper approach. They would painstakingly dissect and only cut the tiny nerve branches going to the parietal cells, the acid makers, but they carefully saved the nerves of Le Target, the crow's foot, that drive the pump.
So the pump still works, but the acid is gone. That's very elegant. But messing with the plumbing has consequences. We call these post-gastrectomy syndromes. Let's talk about dumping. This is the big one.
Dumping syndrome. It's exactly what it sounds like. It happens when the pylorus is bypassed or destroyed. Food just dumps into the small bowel way too fast. But Baily and Love distinguishes between early and late dumping, and the mechanisms are completely different. You have to know both.
Let's do early dumping first.
This happens maybe 20, 30 minutes after eating. It is a fluid shift problem. Imagine you eat a meal with a lot of sugar and salt. It dumps into the jejunum. That food mass is hypertonic. It's very concentrated.
So osmosis kicks in.
Violently, the bowel tries to dilute it. It sucks fluid out of your bloodstream and into the gut lumen. It's like an internal hemorrhage of plasma. The patient's blood volume plummets. They get dizzy. They sweat. Their heart races, tachycardia, and they get explosive diarrhea. They basically go into hypovolemic shock and faint.
That sounds absolutely miserable. And late dumping.
This is a couple of hours later, maybe 2 to 3 hours. This is a sugar crash. The food hits the bowel so fast and the sugar absorbs super fast because the pylorus isn't there to slow it down. Your blood sugar spikes through the roof.
So the pancreas wakes up and overreacts.
The pancreas panics. It sees this massive sugar spike and it releases a huge surge of insulin to deal with it. But the food moves through the gut so fast that the sugar is absorbed and gone very quickly, but all that insulin is still floating around in the blood.
An overshoot.
A massive overshoot. The patient crashes into profound hypoglycemia. They get the shakes, confusion, intense hunger. So early dumping is osmotic shock. Late dumping is reactive hypoglycemia.
That is a crucial distinction. One is about fluid, one is about insulin. What about bile vomiting?
This is a nasty one. In a Billroth II, that loop reconstruction, sometimes bile can swim upstream, refluxing into the stomach. The stomach mucosa absolutely hates bile. It causes a severe burning chemical gastritis. The patient vomits this bitter green bile, but the vomiting doesn't relieve the pain because the stomach is still inflamed.
How do you fix that kind of plumbing disaster if you have bile washing back into the stomach?
You need to divert the bile much further away. You need to convert them to a Roux-en-Y.
Explain that shape to me, the Y.
Okay, picture the letter Y. You cut the small bowel. The bottom stick of the Y is the channel where food and bile finally mix together and go on their way. One arm of the Y brings food down from the stomach. The other arm of the Y brings bile from the liver and duodenum. You make that bile arm really long, like 40 to 50 centimeters.
Why so long?
It acts as a one-way street. Peristalsis is always pushing everything down. The bile simply can't swim upstream against 50 centimeters of traffic to get back to the stomach. It very effectively solves the reflux problem.
That is very clever engineering.
Okay.
Okay, let's do a quick plumbing check-in. If I say a patient faints 20 minutes after eating a big meal, is that early or late dumping?
That's early, osmotic fluid shift.
If they get shaky and confused 3 hours later?
That's late, the insulin spike.
And if they're constantly vomiting green fluid after a Billroth II?
They need a Roux-en-Y conversion to fix the bile reflux.
If you can't visualize that Y shape or the Billroth loop, I strongly suggest you pause here and look at the diagrams in Chapter 67. The plumbing diagrams are absolutely essential. You have to be able to draw them from memory.
Absolutely. If you can draw it, you understand it.
Section 5. When it goes wrong. Emergencies. Let's start with the absolute catastrophe, perforation.
This is the hole in the wall. The ulcer burns right through the stomach or duodenum. Acid, food, and bile leak into the peritoneal cavity. It's a chemical burn of the peritoneum, and it is intensely, unbelievably painful.
The classic presentation is, it's very dramatic.
Sudden, severe thunderclap pain. The patient lies perfectly still because any movement, even breathing, hurts. And here is the classic physical sign: board-like rigidity. The abdominal muscles spasm so hard to protect the gut that the belly literally feels like a piece of wood.
And the diagnosis.
An erect chest x-ray. You have to stand the patient up. The air that leaked out of the gut floats to the highest point. You see a crescent of free air under the diaphragm. That's a surgical emergency, no question.
But there is a trap, isn't there? The elderly patient.
This is terrifying. An elderly patient, maybe someone on steroids for arthritis, might have a huge perforation, but their immune response is so dampened, the steroids mask the inflammation. They might not have that classic rigidity. They might just look a bit off, confused, or have a low blood pressure. You have to have an extremely high index of suspicion.
So how do we fix a hole in the duodenum? We don't just stitch it up, do we?
Well, we do stitch it, but the tissue around the ulcer is often inflamed and friable.
Oh, yeah.
It tears like wet blotting paper. If you just pull the stitches tight, they'll rip right out. So we use the Omental patch or the Graham patch.
Nature's tire plug.
It's exactly that. We take a piece of the omentum, that fatty apron that hangs over the gut, and we literally plug the hole with it. We stitch the fat over the ulcer. The omentum brings its own blood supply and seals the leak like living putty. It's a brilliant, life-saving maneuver.
Okay, now for the other big emergency, bleeding. Hematemesis, which is vomiting blood, or melena, the black tardy stools.
Right. We already mentioned the posterior DU eroding into the gastroduodenal artery. That's a torrent of arterial blood. But it could also be a gastric ulcer or a Mallory Weiss a tear in the esophagus from vomiting too hard. Or it could be a Dieulafoy lesion.
Dieulafoy lesion, that's the silent sniper, right?
That's a perfect name for it. It's a weird, abnormally large artery that runs right under the surface of the mucosa, usually high up in the stomach. There isn't a big ulcer over it. It's just an anatomical anomaly. It just pops.
So you go in with the endoscope.
And you just see a jet of arterial blood pumping out of what looks like normal stomach lining. And the terrifying thing is, if the patient's blood pressure drops and the vessel collapses, it can disappear. The mucosa looks normal again. It's incredibly hard to find unless it's actively bleeding when you look.
So what's the management for a big upper GI bleed?
Resuscitate first. ABC. Don't rush to the scope if the patient is dying in front of you. IV access, fluids, blood products. Then endoscopy. You try to clip the vessel, inject adrenaline to constrict it, or burn it with diathermy. We use the Rockall score to predict their risk of rebleeding or death after the scope.
And if endoscopy fails?
Mhm.
You just can't stop the tap.
Then it's surgery. You have to open the duodenum or stomach, you find the bleeder, and you underrun it, which means putting a deep stitch all the way around the vessel to ligate it. You have to be aggressive.
Let's look at another case study too. An elderly female, 75 years old, history of rheumatoid arthritis, takes steroids and NSAIDs. She collapses at home. In the ER, she's hypotensive, low blood pressure. Her abdomen is distended, but it is not rock hard. She's taking very shallow breaths.
The shallow breathing is a huge clue. She doesn't want to move her diaphragm because there's air or fluid irritating it. The steroids are masking the board-like rigidity. This is a perforated peptic ulcer until proven otherwise.
You do bloods. Her amylase level is slightly elevated. Does she have pancreatitis?
Don't fall for it. That's the trap. Perforated ulcers can release some amylase into the peritoneum, which then gets absorbed into the blood, but it won't be in the thousands like you see in acute pancreatitis. If you assume it's pancreatitis and put her in a ward to rest the pancreas, she dies. A CT scan is the gold standard here. It will show the free air and the fluid. She needs resuscitation and a gram patch stat.
That is a life-saving distinction. Always doubt the amylase if you suspect a perforation. Okay, section 6, the silent killer, gastric cancer. This is a heavy topic, but absolutely essential.
It's one of the biggest cancer killers worldwide, but the geography of it is fascinating. Japan has a huge incidence of gastric cancer, but they also have amazing survival rates.
Why is that? Is the cancer different there?
No, the screening is different. Because it's so common, they have a national screening program. They scope people aggressively. They catch it when it's early gastric cancer, just confined to the mucosa. In the West, we usually catch it late when it's advanced and has already invaded the muscle or the lymph nodes.
And in the West, the location of the cancer is changing.
It is. We're seeing fewer distal cancers, the ones in the antrum that are linked to H. pylori, because we're getting better at treating the bug. But we are seeing a massive rise in proximal cancers at the cardia, the gastroesophageal junction, and this is linked to reflux, obesity, and Barrett's esophagus.
Let's talk pathology. Baily and Love uses the Lorne classification. Two main types.
Intestinal type and diffuse type. Intestinal type looks like a gland, a bit like colon cancer. It's often polypoid. It forms a discrete lump. It's associated with that metaplasia sequence we talked about. It has a slightly better prognosis, relatively speaking.
And the diffuse type.
That is the nightmare scenario. It doesn't form a lump. The cancer cells infiltrate the wall individually. They're called signet ring cells because the nucleus gets pushed to the side by a big blob of mucin, making it look like a signet ring.
And how does this affect the stomach wall itself?
It causes linitis plastica, the leather bottle stomach. The cancer spreads through the muscle wall, making the whole stomach stiff, thick, and rigid. It can't expand at all. On a barium X-ray, it looks like a shrunken old leather bottle.
And the prognosis?
Very poor, because it spreads microscopically far beyond what you can see or feel.
Gastric cancer is notorious for spreading to some very specific, weird places. We have some classic medical student eponymous signs here. I want to run through them because they really help us understand the pathways of spread.
Oh, the class.
That's a lump in the left supraclavicular fossa, the hollow above the collarbone. The lymph drains up the thoracic duct from the abdomen. If you feel a hard node there, it's very bad news. Cisteriosis nodule, a hard lump at the umbilicus, the belly button. The cancer spreads along the old fetal ligaments to the umbilicus, named after the nun who was a surgical assistant to Dr. Mayo and noticed it while prepping patients.
This one is terrifying. Drop metastases. Cancer cells fall off the stomach, float down through the peritoneal fluid, and land on the ovaries. You find a stomach cancer presenting as a large ovarian mass.
You feel a hard shelf of tumor on a rectal exam where the cancer cells have settled in the bottom of the pelvis, the rectovesical pouch.
This all emphasizes why staging is so critical. We don't just do a CT scan and call it a day.
No. CT is great for liver mets and big nodes, but it completely misses those tiny peritoneal seeds that drop metastases. That's why we almost always do a staging laparoscopy, put a camera in just to look around before we commit to a massive operation. If you see tiny white seeds on the peritoneum, the cancer is incurable surgically. You don't want to put a patient through a huge operation if you can't cure them.
And for the depth of the tumor itself, the T stage.
US, endoscopic ultrasound.
Yeah.
Put an ultrasound probe on the end of the endoscope. You can see exactly how deep the tumor goes into the wall of the stomach. It's the absolute gold standard for T staging.
Finally, the surgery. Radical gastrectomy. We have to talk about the D numbers. D1 versus D2 lymphadenectomy. This is a massive debate in the text.
It is. When you remove the stomach for cancer, you have to remove the lymph nodes where the cancer might have spread. A D1 resection means removing the stomach and the nodes right next to it, the perigastric nodes. Station 1 nodes. A D2 resection means removing those nodes, PLUS, the nodes along the major arteries, the hepatic, the splenic, and the coeliac arteries. It's a much bigger operation.
So D2 is a wider, more radical clearance.
Ideal, yes. The Japanese surgeons proved decades ago that a proper D2 improves survival. But, and it's a huge but, it is technically much, much harder. Digging around the splenic artery and the pancreas tail to get those nodes is dangerous. You can damage the pancreas or the spleen.
So in the past, Western surgeons tried to do D2s and had very high complication and mortality rates.
Exactly. For a while, the data showed they were killing more patients with the surgery than they were saving from the cancer. But now, in specialized high-volume centers, D2 is the standard of care. It gives the best chance of cure if you can do it safely.
And usually we give chemo before surgery now, right?
Yes, neoadjuvant chemotherapy.
Yeah.
Of the MAGIC trial, a famous UK study proved that giving chemotherapy before surgery shrinks the tumor and treats any micrometastases that might be floating around. It significantly improves survival compared to going straight to surgery.
We have covered a massive amount of ground, from the cellular pumps to the intricate lymph node stations. Let's just recap the absolute highlights to solidify this.
We started with the fortress. Remember the criminal nerve of Grassi, that posterior branch that causes recurrent ulcers? Remember the proton pump working against a 1,000,000-to-1 gradient and how PPIs jam that pump?
We moved to the game changer, H. pylori, wearing its ammonia spacesuit, tricking the G cells into hypergastrinemia and causing that duodenal metaplasia.
We differentiated the ulcers.
Right.
Anterior equals air, perforation. Posterior, bleed, JDA artery. If you remember nothing else, remember that.
We walked through the plumbing of Billroth I and II and how early dumping is a fluid shift while late dumping is an insulin crash. And finally, the nightmare of diffuse-type cancer and the absolute necessity of a proper D2 lymphadenectomy in the right hands.
It's a comprehensive tour of the upper abdomen.
Here is a final provocative thought for you to take away. We spent a lot of time talking about killing H. pylori, and rightly so. It causes ulcers and it causes distal stomach cancer. But as H. pylori rates have plummeted in the West due to antibiotics and better hygiene, we've seen this huge spike in proximal cancers, the reflux-related ones, and also in autoimmune diseases like asthma and allergies.
There's a theory called the disappearing microbiota hypothesis. H. pylori has been with humans for 50,000 years. Maybe it was actually part of our normal gut flora, regulating our acid levels. By eradicating it, we may have unleashed uncontrolled acid on the esophagus. We tampered with an ancient ecosystem, and now we're dealing with the new, unforeseen consequences.
Is the stomach's ecosystem far more delicate than we ever thought? Something to mull over.
Indeed. It's never just a bag of acid.
Your call to action today. Open Baily and Love, Chapter 67. Find figure 67.29. It shows the lymph node stations. It looks like a map of the London Underground, but you need to visualize where those stations are to understand the principles of the surgery.
And seriously, look at the plumbing diagrams for Bill Roth versus Rouen Y. Take a piece of paper and try to draw them. If you can draw the loops from memory, you understand the physiology.
Keep studying, keep curious, and don't let the criminal nerve of Grassi catch you off guard.
Or that silent sniper.
See you on the next deep dive.